Thanks very much for the opportunity to be involved in this debate, and I'm looking forward to a good, thorough discussion and the challenges thereof. I'd like to recognize my co-conspirators who helped us out with this presentation and the talk. I don't have any disclosures. I would like to welcome everybody who's listening to us from Baltimore. And it's a bright, sunny day out here right now, and it's very pleasant. So these are the reasons I will never do outpatient shoulder arthroplasty. I think my major concern with the whole thing is it's not really about the patient, it's about the money. And I think that probably we wouldn't be having this conversation if there wasn't pressure from the insurance companies and maybe even the government. The other thing too is I think the comorbidity restrictions leave very few patients eligible, particularly in my practice, where the average patient has a liver transplant or something. Also, the literature on this subject is really pretty skewed. If you look at all the reported data, it's all level 3 to 5. There's really no ASC data available, as it's not really routinely collected by any regulatory agency. The last thing is any complication, I think, is a bad complication. I think if someone has a complication, it's going to always be worse at home. And if one patient were to ever die after an operation that I did in an ASC at home for some complication or another, I probably would not forgive myself. And sort of in tandem to that, neither would the lawyers for that patient, especially in the United States. Also, I think setting up a system is pretty much an administrative nightmare, and going through all the committees and going through all the stuff. I think you have to have a lot of support to get that done. Patients with complications also will go to the nearest hospital, which means that I can't even see them except as a guest. But then that's against the law, because you can't practice medicine in hospitals that you're not privileged. And then there are really no benefits to the physicians. I think if you look at what outpatient surgery does for us, it makes it maybe so that we don't have to do rounds and we can make money if we own the surgery center. So I think that there's all sorts of reasons, and I'll go through some of these in more detail. Let's talk about the money. Basically, there's no doubt that outpatient total shoulders are less costly than ones done in the hospital. There's a 40% reduction if it's done outpatient than inpatient, and the reimbursement for 30 days after surgery is really about the same, regardless of whether it's outpatient or inpatient. So I think the money is definitely better in terms of the payers. The cost does depend on location. There's a study by these guys in JSS International and found that actually in-hospital costs and outpatient hospital costs are actually quite similar, whereas the biggest cost savings are in the ambulatory surgical arena, as stated by our esteemed colleague. This is also difficult, the selection criteria for patients. This is the flow chart done by Dr. Throckmorton, who's really done a lot of the great work on this. But who does the screening? Who knows what's a bad predisposing condition and who doesn't? The populations will also differ significantly from inpatient to outpatient in terms of their comorbidities. So the contraindications to outpatient, as suggested by these authors, is any patient over 70 years of age who has hypertension, pacemakers, anemia, obesity, chronic heart or lung disease, or pulmonary disease. And this really knocks out a huge percentage of my population. At Hopkins, it goes even further. You almost can't have a cardiac condition. We see a fair number of sickle cell patients. We have lots of transplant patients, people with difficult airways. Anybody that's an ASA 3 or so can't be done at our ASC. So the really percentage of my population that could be done as an ASC for a shoulder replacement is very narrow. So the contraindications for doing it, again, depend on your practice. Again, less than 10% of my practice would qualify, but this is actually the opinion of Brolin, who also suggested that you need a certain number of TSAs to be competent and to have a proper staff that knows how to do the procedure. At our ASC, I'm still getting rotating for just cuffs and things. I get rotating techs, and it really makes it tough when you don't have somebody who knows what they're doing. So let's look a little bit at patient comfort and pain relief as an outpatient. Boulot in his group looked at people who might want to have the procedure, and of 36 eligible patients, almost half refused to have the same day discharge, and 2 patients had to stay for hypertension control and pain. So only about 50% of this very selected cohort even wanted to have it done, or were happy having it done. In terms of patient satisfaction, similarly, Leroux found that 50 patients, 97% were satisfied. 2 had to spend the night in the hospital. Taney also found that 88% were satisfied and they would undergo the surgical procedure again. But again, it's a very small population. It's 21 patients in fairly selected group. This study was done looking at which patients were admitted and not admitted. It was comparison or meta-analysis, and it suggested that there are high risk of bias in these studies in terms of who was allowed to have the surgery and who weren't, and that further study really needed to be done to iron out these inconsistencies. As far as readmissions, our group actually matched cohorts for age, sex, ASA, et cetera, and ended up with these numbers, but found that the 30-day readmission rate with outpatients was 3.4% versus inpatients who were sent home and did perfectly well. So I think there is definitely a risk of readmission if they're done as an outpatient versus inpatient. Ahmad et al. Also did a meta-analysis, and they found that the readmission rates were very similar, but the big issue, as I mentioned earlier, is where do the patients go if they're readmitted? In our locality, if they go to an ambulance, or if they're called an ambulance, it goes to the nearest hospital. It doesn't go to our hospital, and that's very difficult to ask your colleagues in other hospitals to take care of your patients. So I think that's also a real difficult thing to deal with. I also wonder about infection rates. Another cohort maxed for age, et cetera. They found a higher infection rate with outpatients versus inpatients, and they said it was statistically significant. Probably depends on who you study. If you also look at morbidity and mortality, there's really not very good data on mortality. This article in the lay press found that patients, that none of these are really counted, but across the country, 260 patients had died for outpatient procedures in ASCs. And it's very difficult to know exactly if there have been some deaths after total shoulders or not. So it's kind of an unknown, as I was mentioning earlier about somebody dying, that would really certainly be bad for everybody. Kramer looked at a national database looking at the 1-year mortality in outpatients versus inpatients, and it was really similar. I think, though, that in the United States, the first one that dies is going to cause a ripple across the ocean, because it's really almost an unacceptable thing, even though some patients die in the hospital. It's also an administrative nightmare. I think the physician has to be involved in all the plans and all the committees, and you have to have a system to deal with the complications at night, and also who's going to see the patient the next day or so if they need to be seen, if you're in the OR all day, et cetera. Throgmorton also set up a system where there was a post-op anesthesia care unit. They had one of the staff members call the patient each day. There's a hotline for the patients to contact on weekends and hours after business hours, rather. And you got to set all this stuff up, and you have to have a very good system that's not going to let people fall through the cracks. And I think that's very difficult to set up in any hospital. Also, you want to know how far the patient lives away. You know, if they have problems and they're 2 hours away or 5 hours away, as many of my patients, how are we going to deal with that? And how do you see the patient, or who answers the phone calls? Is it going to be a resident, a second-year resident who doesn't deal with these? Is it going to be somebody in the ER? So I think also to make it work, you have to have a sufficient amount of equipment. If you drop something on the floor, is there a backup instrument or not? Whereas we have that in the hospitals. We also need skilled OR nurses and technicians, which is hard enough to get in the inpatient setting. Many of the people who recommend this have nurse navigators, they have patient educators, they have 24-hour phone responsiveness. There also have to be financial incentives for people who have to stay late. And certainly you have to have a lot of teamwork. So I think there are lots of elements to this that are sort of hidden. So just talking about inpatient versus outpatient, there's a lot more to it than just sending the patient to the outpatient center and having them go home. So insurance companies are also making it difficult already for us as providers, saying that that the patient's too healthy to be done as an inpatient. Aetna is probably the worst at that right now. And somehow I'm not really sure how they can say this, because it's really not and adopted as a standard of care. And so obviously for them, it's about the money, and it's not about people setting up systems that are careful and helpful for patients. So in the end, is it worth it? Again, what about the patient who lives far away? Who's going to set up the systems to deal with patients? Who's going to see the patients? Who's going to answer the phone calls? I think those are all things that have to be answered before we can really dive into doing this on a routine basis. So for me, the answer is no. I think this has been designed not so much for safety of the patients, but for a cost-saving measure. And I think it's something that we really don't need to do. I think you have to also have facility or institutional buy-in. That's very difficult in academic institutions unless they see some monetary basic benefit. And in the long run, it's probably just not worth it. I mean, I think all the effort that you have to put into a new system that is unproven is probably not necessary. So thanks very much, and look forward to the discussion.